All right, let's try this again. People keep calling my phone and knocking me off. All right, we're going to go to chapter 5 in your pharm book. Starts on page 65, anti-infectives, antibacterials, antituberculars, antifungal agents. And we're going to start on slide 4 on your slides where it says overview. So we're going to look at what a pathogen is. This is on page 65. Pathogens are organisms that are expected to cause infections or illnesses. Underneath this title, we have bacteria, fungi, viruses, and parasites. And it talks pretty well about those in the book. When we think fungus for a person, the first thing that I usually think about is yeast. But there can be other funguses, but yeast can go a lot of places in the mouth, in the vagina, on the feet, in the growing area of men. So usually think about yeast when we talk about fungi. And then we've got viruses and parasites. We've got a big word there, antimicrobials. And antimicrobial is anything that is designed to fight off one of these pathogens. It just means that if it's a virus, then I've got an antiviral. If it's a fungus, I've got an antifungal. All right, so it's kind of a broad term. I don't want to miss a couple of things on 65 under normal flora. You didn't have a slide for this, but I want you to make sure you understand that normal flora can also turn on me. I know we've talked about it in med-surg, but in normal flora, if my immune system drops, then my own flora, my own good bacteria can take over and I can have an overgrowth. And a lot of times that means I end up with a fungus infection, like a yeast infection. But I also want you to make sure that you understand antibiotics can do that as well. And we said before, antibiotics drop my immune system to some point. But so if I take a lot of antibiotics, it's pretty common that I get a yeast infection. Sometimes women get vaginal yeast infections. Sometimes people get yeast infections in their mouth we call thrush. Next slide on antibiotics. Let's see where we're at. Actually, on the next page on 66 is where they talk about an antimicrobial drug. It says that an antimicrobial, same thing as an anti-infective, are drugs that can either kill or inhibit the spread of an infectious agent, such as those things that we talked about in the slide before. And then we're going to go down to talk about antibacterials. And an antibacterial is something, it's the term that we use to describe a drug that will either kill or stop the growth of a bacteria. It says an antibiotic is any drug that has the ability to destroy or interfere with the development of a living organism. In anti-infective therapy, the term antibiotic is used interchangeably with an antibacterial. So we use the word antibiotic and antibacterial, same word. Okay, same word. When it comes to antibiotics, we've got a couple of different very broad areas to look at. We've got a broad spectrum antibiotic, and those antibiotics are something that covers a lot of different bacteria. So sometimes when I'm sick and I don't really know why, and the test results are not back yet, a doctor may put me on a broad spectrum antibiotic to try to cover all the bases. A narrow spectrum antibiotic would be something that I would see if the doctor did know what kind of bacteria I had. Okay. Now there's a couple of tests that we need to do for sure to understand what kind of bacteria is present in the body. Number one is a blood culture, okay, or a culture of whatever it is, a culture. If I have a wound, then they'll culture the wound. If I have a respiratory infection, they'll culture my sputum. If I have an infection on the inside, they'll culture my blood. But I have to make sure that I culture that, all right? And when that happens, I don't get automatic results. I don't get finalized results until after 3 days, 72 hours. But every 24 hours, I'll get a report to see if there's any growth. So what they'll do is they'll culture that area and they'll watch to see what kind of bacteria come out of it, all right? And that way they'll know they need to do a test called a sensitivity. So when they do a sensitivity, they find out what bacteria it is and they run it through their machine and it shows them what kind of antibiotic that bacteria is sensitive to, what it is able to be killed by. And that would be a narrow spectrum, all right? So for instance, let's say I'm working in labor and delivery and I have a girl come in and she has complaints of what really kind of feels like to me a urinary tract infection, all right? Now doctors can take this a couple different ways. If she's not symptomatic, she's not really feeling horrible, they may wait the 3 days to see what kind of antibiotic is really the best for it. Now, if she comes in and she's very sickly, then they'll probably give her a broad spectrum antibiotic and then wait for the test results to see if they need to change that antibiotic to something else. Really just depends. Okay, but again, it takes about 3 days. So I'm going to definitely need a culture and sensitivity. Now, there's other blood work that I can do. I definitely want to look at a CBC and maybe a CMP, which is a complete metabolic panel. And on my metabolic panel, it's going to show me things like my electrolytes and stuff like that. So it just depends on what's going on with the person. But definitely need a culture and sensitivity. Under adverse reactions, I want you to know the difference between a side effect and an adverse reaction. Side effects are things that I expect to see. So all antibiotics, I expect to see the side effect of diarrhea. That's just how it goes, all right? All antibiotics have the side effect of diarrhea. So if a patient called me and said, hey, I've got loose stools, I'll be like, okay, that's a side effect. Keep on taking your drug. Now, an adverse effect is something that can be quite dangerous for the patient, so I want them to stop it. So if the patient called me and said, every time that I take this drug, I pass out. Or every time I take this drug, I vomit profusely. Every time I take this drug, my throat swells. Those are definitely adverse. Those are very bad things, and I wouldn't want them to take that drug anymore. So know the difference between those two things. Next slide, we're going to go to penicillins. Actually, take a step backwards for antibiotics. And I don't see a slide on this either, so we're going to say it's with slide 5. Underneath antibiotics, it talks about bactericidal and bacteriostatic, okay? Those are how I classify antibiotics. Bactericidal antibiotic ends in cidal. There's lots of other words that end in cidal, like homicidal, suicidal. Those all end in death, all right? So a bactericidal drug will kill the bacteria, whereas a bacteriostatic drug will only halt the progression of the bacteria. It will stop or slow down the growth of the bacteria that's in there, all right? So it weakens it to the point to where it'll eventually die. But both of these drugs kind of end that way. But bactericidal, of course, will go in and kill the bacteria, whereas bacteriostatic kind of halts it and weakens it till it eventually fizzles out. All right, so on page 67, you've got general nursing implications for antimicrobial therapy. That table, 5.1, is way too big to go over on these videos. It is hugely important that you read that. Hugely important, okay? I have highlighted a couple of things that I want you to highlight as well at the very bottom under planning and intervention at the very, very bottom. I want you to make sure that you really are looking at that. Antimicrobials work best against infections when there's blood levels there consistently all the time. So let's say that a doctor orders an antibacterial or whatever, antibiotic, whatever you want to call it. He orders it every 12 hours. Now, most of us will go home and take it well, let's say he orders it every 6 hours. That's a better one. Most people will go home and take it every 6 hours while they're awake. But it will work best if you take it every 6 hours around the clock. So 6-12, 6-12. That's how it works best because I keep a continuous amount in my bloodstream. Up at the top for assessment, a couple of things, something that I had highlighted I want you to highlight. Remember, I want you to read it all, but these are important. If ordered, obtain specimens for culture and sensitivity before starting your antibiotic. If I start that antibiotic before I draw my culture and sensitivity, the test will mean nothing. All right, so always draw your culture and sensitivity before you give the first dose of antibiotics, always. Under planning and intervention, again, I don't have it highlighted, but I see the word pseudomembranous colitis, and that's C. diff. And some of my strong antibiotics can actually cause me to get C. diff. So really read that area, okay? Under evaluation, I also have highlighted reevaluate any lab work that has been ordered so the adverse effects like liver and kidney damage or altered drug levels can be prevented. And now I say that when we get into each individual classification, you're going to understand why. A lot of these drugs are very, very hard on my liver and kidneys. So I want to make sure that I'm looking at lab work, not only to make sure my white counts are getting better or the infection's going away, but also to make sure that I'm looking at my liver and kidney function. Also want to talk about the generations. It talks about those at the bottom of 67. The generations are just something that lets me know that something has been improved. So I know we talked about Benadryl for the last chapters in Med Surg, so let's talk about it again. So Benadryl is, not in this chapter, of course, but a Benadryl is a first-line drug, all right? It was one of the first antihistamines ever made, so it's a first-generation drug. Well, there's some side effects to Benadryl, one of those being sleepiness. People get really sleepy when they take Benadryl. Now, to me, that's a desirable effect. For a lot of people, it's not. So we knew that people need antihistamines, so we came up with drugs that made you less drowsy, all right? And those would be the second generation. So every generation that I see supposedly gets better and better and better. The chemical makeup is better and the side effects are less, all right? And that's typically how generations go. The next page on 68, before we get to penicillin, I want you to look at box 5.2, the general teaching points for patients and families during antimicrobial therapy. I have got that starred a zillion times. I want you to make sure that you're really reading through that box and asking me any questions that you have about it, okay? These are very important. Explain that diarrhea is ordinary unless it gets out of control. If you have excessive watery or bloody diarrhea, we need to know. Remember the difference between side effects and adverse effects. Stress to the patient if they develop a lump in the throat, difficulty breathing. That sounds like anaphylaxis, right? I need to know if they're having those problems because they need to come off the drug. Make sure they take their drug. What's hugely important about antibiotics is that they take them as directed and they take the whole thing. They can't stop taking them because they feel better. They have to take the whole run. When we start doing things like that, we develop superbugs. So they have to take all of their therapy, even if they feel better. It talks about a rash, and my big rule of thumb about getting rashes, or hives, I like to call them hives, is that I always feel like hives are a precursor to anaphylaxis. So if people are breaking out in hives, the next step could be their airway swelling. So I definitely want them to tell us about that. And I'll let you keep reading through that box. It's a really great box. So now we can get to slide 6, penicillins. All right, for penicillins, what I really want you to focus on is you going over to page 70 and looking at the boxes, okay? The boxes are fantastic, and they usually get you what you need for the medications. You definitely need to remember this classification of penicillins. You probably don't have any drug cards at home. If I could figure out a way to get you drug cards to you, maybe you could do them online. Maybe you could just write them out. I'm not sure. We'll talk about drug cards tomorrow. But penicillin would be one of those things. All right. Penicillins are some of our original antibiotics. If you notice underneath there, all those drugs end in cillin, and that's what you need to remember. All of my penicillins end in cillin. So I've got penicillin, amoxicillin. Let's see here. Well, that's all it really says there. But that ends in cillins. The nursing implications in your box on table 5.1 are very important. Some things to point out. I want you to read all of them, but some major things to point out there is make sure that you mix it well. Okay, a lot of our penicillins, they separate, so you have to shake it up to make sure that it's mixed well. This is for any drug. Patients are never to chew extended release drugs. Those are designed to dissolve in the gut and not be chewed up or broken. Penicillin G, procaine, is never to be injected to a blood vessel because procaine can cause severe neurovascular complications. Procaine is a type of anesthetic. It's designed to numb things, and those should never go in the vein. I have this highlighted, and this is very important. With penicillin G, use the Z-track method for IM injection into deep muscle. As a matter of fact, for any deep muscle IM injection, Z-track would be the choice to take when doing an injection. Now, here's something that we think about all the time. We don't really know. Each book says something different, but this book tells you to aspirate before you inject the medication for an IM injection. Your other book, your med-surg book, says not to aspirate. So I'm going to go with the newest information out there, and it's to do not aspirate. And then the rest of it you can just read. All right. So on your slide, it says it's your main antibiotic for years. A lot of people have grown allergies to penicillins, though, so we have to watch out. Definitely the overuse is a big problem. We used it for everything. People stopped taking it. We put all kinds of these penicillins into our meat. Man, we just really You guys should really Google sometime the timeline of how we used penicillin. It's amazing. So now because we did that, we have our penicillin resistant strains. So a lot of our bugs out there, our super bugs, have become resistant to penicillin. So we've had to go opposite ways and find other medications, antibacterials, that could work for what we would normally give for penicillin. Not that we don't give it. We still do give penicillin. We give amoxicillin quite often. But a lot of people are allergic, so there's other options. And we'll talk about those a little bit later too. And penicillin is also the broad spectrum drug of choice. If the patient's not allergic to whatever it is, before we find out what the bacterium is itself, a lot of times they get put on a penicillin. Penicillin's continued on the next slide. The action and uses interferes with the creation of mucopeptide cell wall. All right, if you look at the top, on your table, it says penicillins and cephalosporins are cell wall synthesis inhibitors and kill susceptible bacteria within the cell walls by preventing cell walls from being made and maintained. So anytime I have a drug that's a cell wall synthesis inhibitor, my cell walls for my bacterium have to be pretty strong. All right. If the insides are exposed, then my body can digest it, send out those phagocytotic cells and kill it. All right. So my bacterium has to have cell walls. Without those walls, they can't survive. So any drug that says they are cell wall synthesis inhibitors, that means they do not allow the cell to make its wall. And thus, when it doesn't have a wall, it can't survive. Pretty easy, right? That's all you really need to know about a cell wall synthesis inhibitors, okay? As what they are. We use it to treat multiple infections. Looking over into your text. Let's see if I have any things really highlighted here. We did look at the action. That's your cell wall synthesis inhibitor. For uses, it says we treat multiple things, but I do have highlighted syphilis. That's still the drug of choice for syphilis and certain types of endocarditis. It says penicillin is also used for prophylactic treatment against bacterial endocarditis in patients with rheumatoid or heart disease before they have dental procedures. Very important one. So people who have heart problems, we don't even think about it, but our teeth and our heart are closely related. So people might get penicillin before they go have any dental work done if they have heart problems. Other than that, those are the main points about penicillin, down to overuse and allergies. Overuse, of course, we've talked about that multiple times. That has left us with drug-resistant strains of bacteria that don't penicillin doesn't work against anymore, and we've caused all these allergies. Lots and lots of people are allergic to penicillin. As a matter of fact, you might have quite a few patients that say, I'm allergic to penicillin. You'll say, what does it do to you? Because you should always ask that. And they say, I don't know. My mom just told me she was allergic to it, so I was too. Doesn't really happen that way. All right, so we need to find out what's actually going on when they have an allergy. Slide 8, penicillins continued. Adverse reactions to penicillins are neuropathy. Neuropathy, and that's usually in high doses, it says. And neuropathy means that I lose feeling in my feet, my hands, and it causes pain and numbness and tingling. Skin eruptions, I can have those like sores that pop up. GI upset's probably the most common one. Penicillin, well, just about any antibiotic is very hard on your stomach, but GI symptoms are definitely huge when it comes to penicillin. In your book, I've also got highlighted the C. diff. It's an infectious form of diarrhea. You want to make sure that you understand that I can get C. diff if I have to take a lot of penicillin. Just depends on how well my immune system copes with it. Urticaria is itchy red skin that can be caused by penicillin. Laryngeal edema is definitely when your throat starts to close up. That would be anaphylaxis. Okay. Drug interactions. Actually, going back a little bit, those are all adverse, but I want to list another one as it talks about angioedema. And remember how we said before, if my eyes start swelling around them, and then I am in for a doozy. All right. So I need to make sure those patients get off that drug. Get some Benadryl before it gets worse. Maybe even Epi if it's already bad. Drug interactions, I definitely can't take these with tetracyclines and erythromycin because they decrease the effect of the penicillin. Ampicillin's another important one. Ampicillin reduces the effectiveness of oral contraceptives. Oh, excuse me. That's not an interaction. That's an interaction with oral contraceptives. Now, let me tell you about oral contraceptives. Lots and lots of antibacterials do not work well with oral contraceptives. They make the oral contraceptive inactive. They just don't work anymore. So women who are going to go on antibiotics and they take oral contraceptives are told to use an alternate form of birth control. And that's under your top tip for safety right below drug interactions. Penicillins continue on the next slide. Nursing implications and patient teaching, assessment, signs of infection and allergies. When people are going home, I want them to understand what it means to start feeling better. Let them know, if your fever continues, if things don't get better, they need to come back. And definitely those things to watch for for allergies. If they start getting a rash, they need to stop the medication and call or come in. If they have trouble breathing, call 911. Let's see here. I think everything else is pretty much covered in just a very small section in your penicillin section in the book. And I don't really think we need any more. It does talk about a 10-day regimen, and that's just saying that most times if I take oral penicillin, that I'm getting it for about 10 days. Route of administration, of course, we can give penicillin a few different ways. Depends on which penicillin it is. An evaluation, of course, just with any other kind of antibiotic, I have to determine whether the patient's getting better or not. I do that by vital signs, physical features, the way the patient feels, and lab tests. I'm going to stop this video because, actually, we're going to keep going just a little bit longer. We're going to try to do cephalosporins. All right, cephalosporins, go to your page 70, went back on the chart. Cephalosporins are also a cell wall synthesis inhibitor, all right? They do the same thing that penicillin does, and they're also broad spectrum, and it says that they actually have activity against gram-negative organisms. Now, there's numerous ways that we classify bacteria. One of those things is if they're gram-negative or gram-positive, and they do that by performing a gram smear. So they'll take actually on a slide, and they'll use a dye, and they'll tell you if it's gram-negative or gram-positive by doing that smear. And gram-negative bacteria are usually much harder to kill than gram-positive. We also classify bacteria by their shape. So remember back in A&P where we have bacilli, cocci, and spirochaete. And that's another reason we can say that if it's gram-negative rods, then it's probably a bacilli, right? Because that's rod-shaped. So I have gram-negative bacilli. And let's see here, what else? Oh, we also classify bacteria by their need for oxygen, whether they're aerobic or anaerobic. One needs oxygen and one does not. So you might hear that this bacterium is a gram-negative bacilli that is aerobic. And that means that it's hard to kill, it's rod-shaped, and it needs oxygen. All right, basically in a nutshell. So your cephalosporins are closely related to your penicillins. So people who are related to your penicillins probably shouldn't take cephalosporins. They do about the same kind of things. So sometimes doctors, if the patients don't have bad allergies to penicillins, they might try them, but you have to watch them very close. But in most situations, you need to let the doctor know, hey, they're allergic to penicillin, so they probably should not get a cephalosporin. Let's see here. Under expected side effects, we've got the norm, nausea, vomiting, diarrhea. That's about normal for all of them. Adverse reactions is hypersensitivity, and that would be an allergic reaction. That's going to be the biggest reaction of all of them, is losing your airway. It also says patients who are allergic to penicillin not to take them. We've said that already. That's called a cross sensitivity. Not the same kind of drug, but very closely related. So they're cross sensitive. We also have a high risk of nephrotoxicity, nephro being kidney, renal, and toxicity being toxic. So we really want to make sure that we're watching the people's kidney function, making sure their urine output is good, and all that good stuff if they're on cephalosporins. So looking at your cephalosporins, you've got the first time that we're looking at first generation, second generation, and so on. And you can see our first generation, we see ceflazoline and cephalexin, I can't even talk, which is Keflex. And those were our first generation. So our second generation, Ceflacor and Ceftin, a little bit better, they think. Third generation, even better. And then fourth generation, we've ended up at Maxapine. And those, again, with each generation, are supposed to get better and better and better with least side effects. Some highlights to remember on the table is do not give oral cephalosporins with 1 hour of taking an antacid. I want you to read all these, of course, but just the basic, the major things. Is giving using a Z-Track with IM injection. Your extended release tablets, again, don't chew them or crush them. They have to be swallowed whole. Here's an important one. Ceftriaxone IV cannot be given with Ringer's lactate. That's an important one. And warn patients not to drink alcohol when taking cephalosporins to reduce the side effect of vomiting, hypotension, and dyspnea. Okay, that's an important one. So that covers... Okay, let's talk about the next one under the drug interactions, because we just talked about alcohol, but that goes along with your severe disulfiram reaction resulting in severe flushing, vomiting, and collapse. So when we said to avoid alcohol, it's because when I drink alcohol with a cephalosporin, I get that, what they're calling severe disulfiram reaction, which causes like you're on a severe, never-ending, horrible drunk, okay? And you really don't want that. It's hard to come out of. It makes you feel very horrible. So no alcohol while taking cephalosporins. We talked about the rest of that slide. Slide 12. Actions and uses. Cephalosporins are commonly used for uncomplicated skin and soft tissue infections, infections of the lower respiratory tract, the CNS, GI, joints, and bones, and sometimes serious infections, it says, like bacteremia and septicemia. Both of those are infections of the blood. You know, that goes on the whole system. And then we see the side effects again, those normal ones. The adverse reactions on the next slide. Hypersensitivity, of course, is having your allergic reaction, your anaphylaxis. We talked about the cross-sensitivity with penicillin, and the nephrotoxicity, super duper hard on your kidneys. All right, and we're going to stop the slides there, and we'll start back again on slide 14.